So our next speaker is Professor Henrik Falhammar from Sweden. He graduated from Karolinska Institute in 1995 and completed his specialist training at Karolinska University Hospital. And since then, he served in several leadership roles, including the director of the neuroendocrine unit, the adrenal unit, and the outpatient clinic at Karolinska. He has also worked in Australia. And he holds a PhD in endocrinology on CAH in adults and is a senior researcher with wide-ranging contributions to adrenal disease. And while his main focus is CAH, he has also published extensively in several other areas of endocrinology. So we are very much excited to have him here as an expert today, and he will share his expertise on novel therapeutic perspectives in CAH.
Thank you for the introduction. Let's see if I can share my screen. And now I can see my slides also. So, yeah, here is my disclosures, and I have disclosures with more or less all the medication I will mention in this presentation. So Heidi showed very elegantly the causes and biochemistry of 21-hydroxylase deficiency, which is the most common. And as you can see, there is a shift from low aldosterone and cortisol to high adrenal androgens. And this low cortisol deficiency leads to a loss of normal negative feedback to CRF and ACTH. And this ACTH in turn increases the adrenal androgen production. So the glucocorticoid treatment in CAH substitutes the cortisol insufficiency, and at the same time it decreases CRF and ACTH production, and that results in lower adrenal androgens. So glucocorticoids gives a possibility for survival and symptom controls. Unfortunately, to have enough suppression of ACTH, we usually need supraphysiological doses. And supraphysiological doses can lead to a lot of different long-term complications, such as elevated blood pressure, increased weight, decreased BMD fractures, and so forth. And high ACTH in turn can also lead to a lot of different things, for example, adrenal rest tumors and large adrenals. And there's heaps of new therapeutic approaches on the horizon, and some have already come, and I will go through some of them. So the first is the hydrocortisone modified released hard capsule, which Heidi already had mentioned. And as you already know, there is a circadian rhythm with the highest level before waking up and the lowest just after we go to sleep. And by having a hydrocortisone modified release capsule, it gives a possibility to more closely reproduce the physiological rhythm of cortisol. And this capsule is given in twice daily or the toothbrush dosing, with the highest dose at bedtime and a smaller dose in the morning. I have a few patients on it. Unfortunately, it's only available in 5 milligrams and 10 milligrams. I would like to have the 2.5 milligrams also. And it's been licensed in Europe since 2021 in CH from 12 years of age. Unfortunately, in a lot of countries in Europe, it's not reimbursed yet, so the cost is quite high. It costs around maybe $350 per month if it's not reimbursed. So here is the physiology. As you can see in the normal physiology, the circadian rhythm, the immediate release hydrocortisone, no doses, no hydrocortisone in the end of the night, and then you have high peaks You have the extended release hydrocortisone, Plenadren, for example, which is not indicated in CH, but in Addison's disease, which is an extended release, and it also doesn't give any glucocorticoids in the morning before waking up. And the modified released, which is more similar but not perfect to normal physiology. And the study, which gave the license in Europe for modified released, was a 6 months randomized phase 3 study in 122 patients with 21-hydroxylase deficiency. And then there was an extension study. And the primary outcome was change in the 24-hour standard deviation score of 70 HOP. And this, as you will see, has some problems, and also to show the safety and tolerability for the extension study. And here are the main results. And if you looked at the lower panels, you can see the comparison in 17 HOP with the modified released hydrocortisone compared to standard glucocorticoids. And as can be seen, the standard has quite low 17 HOP all around the clock, especially in the morning hours, and in a similar pattern also androstenedione. Unfortunately, this complicated measurement, the 24-hour profile, were not statistically significant different between cases and controls. And that's the problem in some countries why it hasn't been reimbursed. And here's similar data, but looking in the morning, there was definitely a significant lower 17 HOP levels or during the day. And the glucocorticoid dose, the hydrocortisone, was increased during this randomized control study from 25 milligrams hydrocortisone baseline up to 30 for both the standard and the modified released. However, in the extended period, it could be lowered by a third down to 20 milligrams and with still good control. So that's the first new treatment, and the next goes to the CRF inhibition. So the step before ACTH, and there's 2 drugs who's been trialed, the crinecerfont and tildacerfont. We start with crinecerfont. And in their landmark study, crinecerfont was compared to placebo in the first 24 weeks. And then there was an open label treatment. And then there's an extension. And in the extension, now it's more than 3 years in total. So adult patient with CH receiving a glucocorticoid dose more than 30 milligrams per square meter body surface. And they have to be on a stable dose. And in this study was in fact the biggest study in a randomized controlled trial with CH, 182 patients. And you can see the characteristics. Mean age was around 30, which is quite common in CH studies. And during the first period, there was the glucocorticoid was stable, the first 4. And as can be seen in panel C, panel C and D, both the androstenedione levels and 17 HOP levels was reduced in those on crinecerfont. And then during the next few weeks, there was a glucocorticoid reduction. So you try to get the glucocorticoid dose into physiological levels. And during that period, of course, both the androstenedione levels and the 17-HOP levels started to increase, but they were never above the baseline levels in those who were giving active treatment with crinecerfont. And in the end, those on crinecerfont, 63% reached physiological dose of glucocorticoids, while in placebo it was 18%. And it was quite safe. Fatigue was quite common, but it could probably be interpreted that you lower the dose, you feel that, and usually the fatigue disappeared, and there was some headaches. And then there was a slightly different, but in some way similar pediatric study. And here you can see the main results. The crinecerfont led to in the first 4 weeks decrease in both androstenedione and 17-HOP. And during the glucocorticoid adjustment, there was a reduction. And in the end, 30% of those on the active substance, crinecerfont, had a physiological glucocorticoid dose compared to 0% in controls. And also here, it was quite safe. And the most common side effects were headache, a little bit of fever, vomiting. It should be noted that most of these patients were recruiting during the COVID epidemic, which might have affected some of these upper respiratory symptoms. And both of these trials were published in New England Journal of Medicine last year. The next drug on the block is tildacerfont. And there was some phase 2 data. Looking in patients with good control, there was only small change in acetate, 17-HOP, and androstenedione. While in patients having poor disease control, there was more of a reduction in the same parameters, while keeping the same glucocorticoid therapy. So from this data, there was a few studies done. The first one was Camellia 203, which was a randomized controlled trial with different doses of tildacerfont comparing to placebo in patients with poor control, but not, it was poor control. It was quite high androstenedione levels, more than 2.5 upper limit of normal. And they had to be on a stable dose of glucocorticoid, more than 50 milligrams per day. And 96 patients were enrolled. And the primary endpoint was change in androstenedione levels at week 12. So unfortunately, this study failed. So there was no difference in androstenedione levels between tildacerfont or placebo at week 12. Unfortunately, the compliance were quite low. So it was only 50% of the patient reporting more than 80% or greater compliance. But it looked pretty safe. So then they had, at the same time in parallel, there was another study going on with a glucocorticoid reduction study in patients with pretty good disease control and on stable glucocorticoid regimen, more than 30 milligrams of hydrocortisone per day. And the primary endpoint was change in daily glucocorticoid dose from baseline to week 24. Unfortunately, this study also failed. So, but in this study, most patients were compliant. And also here, there was no safety issues. And there was also a pediatric study on only 30 children, which was not placebo-controlled. And in that study, there was a trend to larger reduction in A4 with higher doses on BD doses of tildacerfont. So tildacerfont is given once daily tonight, while crinecerfont are given twice daily. And unfortunately, the study program stopped because of these three failed studies. So tildacerfont, there's no development. Currently, there's no development. The next drug is atumelant. It's an oral selective ACTH antagonist affecting the MCR2 receptor on the adrenals. And there is a small study called the Toucan study with between 6 to 12 patients in 3 different cohorts of different doses. So in total, 24 patients. And these patients had to be 21 hydroxylase deficiency. And all these studies has been done in 21 hydroxylase deficiency. And the dose more than 50 milligrams of hydrocortisone daily. And the androstenedione levels more than 1.5 of the upper limit of normal. And as you can see here, on the individual patient on the upper panels or the median in the lower panels, there was a dramatic drop in both androstenedione levels and 17-HOP levels. And it was generally well tolerated. So there's a phase 3 randomized controlled trial who will hopefully commence later this year or early next year. There has been some data shown on a poster presentation, also reduction in the adrenal volume. The next drug is LU-AG13909, which is an anti-ACTH monoclonal antibodies. This has to be given in the trials. It's given as an infusion once a month. But they have developed also a subcut preparation, which hopefully will be used in the future if all studies show positive results. So the phase 1 trial finished this spring and was presented at the ENDO. Unfortunately, there's very little data, public data, so these are the only data available. So it was 11 patients between 18 and 70 years of age who received this once monthly infusion. And the drug was well tolerated, and the morning 17-HOP and A4 was dramatically reduced at 24 hours after infusion. And the phase 2 trials has just started, and we have included one, and I have screened one patient this morning. So we'll have to see more data. Then gene therapy. A lot of my patients, they ask, when will there be a cure? So this is a possibility of the cure. Unfortunately, there is not any paper published, but there has been a phase 1/2 trial with gene therapy. And it's an adeno-associated virus who is recombinant vector encoding the human CYP21A2 gene. And it's giving IV. And it's been trialed in adult males and non-pregnant females. And they had to have elevated 17-HOP levels. And unfortunately, the only result of that trial is from a press release last year, where it said it could be seen some cortisol production. However, there was a failure of the 17-HOP and androstenedione levels, lowering on that. So the company, BridgeBio, stopped developing this by taking away the budget from the program. So there is no development of this company. There is some other guys doing studies in animals, and hopefully we'll see human study in a not too distant future. But this will take a lot more time than the other drugs to see in clinical practice. And I'll briefly mention bilateral adrenalectomies. I'm not sure, but it usually in this list of new treatments, bilateral adrenalectomies is also listed. It's an old treatment. It was used quite a bit previously, and then it's fallen out of practice. But it might come back a little bit. So this is a poorly controlled patient with CH, and you might see that these are huge adrenals. Probably around 20 centimeters in size. So all patients with myolipomas more than 20 centimeters seen here at the Karolinska all have had CH. And this is from another patient, also adrenal myolipomas, had bilateral adrenalectomies. And we did a meta-analysis a few years ago, and at that stage it was only 48 cases published. And the most common reason for doing adrenalectomies was hyperandrogenism in half of cases, and iatrian Cushing syndrome in almost the other half, but also for some cases for fertility. Long-term outcomes, so symptom improvements in 71%, adrenal crisis in around 17%, and there was a couple of live births also. So 4 patients were able to conceive. And the glucocorticoid dose was reduced quite significantly. And here in the figure form, you can see the 17-HOP androstenedione levels and testosterone levels, huge reduction, while the ACTH levels increase. Unfortunately, there's also potential side effects. So high ACTH levels might lead to growth of breast tumors. So this is a patient with both ovarian breast tumors and retroperitoneal breast tumors. So the future in CH, I think, looks very promising. So hydrocortisone modified release, as I said, is licensed in Europe, but unfortunately not reimbursement in all countries in Europe. Crinecerfont was FDA approved in the US in December last year. Unfortunately, it's extremely expensive. So we will see what happens when and if it comes to Europe. Tildacerfont, the development has stopped. Atumelant, they will start recruiting for the phase 3. So we'll see what that will show in the randomized control trial. And as can be seen with the Tildacerfont, I mean, there was some promising results before, but you need to have a randomized control trial. And also with the LU-AG 13909. We'll have to see what happened there in the phase 2 and hopefully in the phase 3. But having all these different trials, we need more long-term outcomes to see that it's not just in the short term. With a hydrocortisone modified release, there is some long-term outcomes, but we need it also for the other drugs. Questions?
Yeah, so first of all, thank you very much for the great talk. That was very interesting. I think there's no questions just yet in the Q&A box. So if you have any, please send them in now. But maybe then I'll just start with a question. So maybe could you give an advice on which patient groups you would use the new CAH medications? Like if you could define patient groups that could actually benefit from, let's say, CRF1 receptor antagonists, who would that be?
I mean, it depends on the cost, and I assume it will be very high, so I will use it for the most difficult ones. Of course, it hasn't been trialed for fertility reasons, but that could be, you know, in the future, if we got some safety data during pregnancy, that would be an ideal patient, you know, someone who's very difficult in conceiving, and then you can give it before pregnancy and maybe during pregnancy, and then you can stop afterward, you know, if you can't afford it. Another one are these patients with huge adrenals. I mean, if you could reduce the size instead of adrenalectomies. So basically, I would probably start with the most difficult ones, and then depending on price and availability, then I'll work my way down. Of course, I wouldn't use it in the ones who have pretty good control and pretty okay glucocorticoid dose.
Thank you. I think there's another quick question in the box. If modified release hydrocortisone is licensed in the UK?
Yes, I think so. I'm not sure about the reimbursement. So I'm not sure. I think I have 4 or 5 patients on FMODI, as the brand name is, but they all participated in the study, and the company gives it out for free because it's not reimbursed in Sweden, and the cost is a little bit high for the patient to pay it. I mean, potentially the hospital could pay for it. I use, for example, in pregnancy, when women with CH want to conceive and they're not successful, then I usually increase the glucocorticoid dose. I mean, in that settings, probably it could be motivated to start the modified release and get the hospital to pay for it if it's not reimbursed.
Thank you. We have 2 more questions. So if the modified release hydrocortisone has been tried in other CAH cases, CAH subtypes like 11-beta hydroxylase, could you comment on that?
I'm not sure. I mean, it's not in studies. You know, it's the same with all drugs and all therapies. We don't have much in the other CH, but I would assume it would have similar effects.
And then maybe one last question. If the other types of newer therapies, if they're used at steroid-sparing medications for those patients who have side effects under conventional glucocorticoid therapy?
Yeah, so yes, of course. So I mean, potentially we could have a patient on a more physiological dose. But these other steroid-sparing drugs, I mean, they don't give the normal circadian rhythm. They just lower the total dose, so it's not a perfect. I didn't mention a IV or a subcutaneous hydrocortisone infusion. That's the most physiological, but it's very difficult, and we have done a trial. Unfortunately, we haven't published it. And also Deborah Merck did the trial, and then there's some other data both from UK and Denmark. And the ones I've talked to, the investigators, they all say it's too difficult to have it in a more clinical practice, maybe in a few patients.
Okay, so I think thank you so much for answering the questions, and it was an excellent talk, very interesting.